Well, good morning, everybody. I think we'll go ahead and get started right on time. We're going to forego introductions because you all know who we are from the app. You can look us up. And we'll introduce ourselves briefly as we each give our initial answer this morning. My name is Gerard Doherty, and I'm the Chair of Surgery for Mass General Brigham, and it's a pleasure to welcome you here. To the surgery session on sort of the future of surgery and get some ideas of what we think surgery will become over the next decade or two. I'll start by saying surgery has never been static. The field, as we would recognize it, has really only existed for the last 150 years or so. Before that, we didn't have many of the tools. But over that 150 years, it has continuously changed. And there's been no two consecutive generations of surgeons who have really practiced the same kind of craft. It has always advanced. There's been different diseases we've treated. There's been different tools we've had and different capabilities we've had. It's never changed as fast as it's changing now. And I think that's what we're going to try and talk about this morning, this recent pace of change, how we adapt to that, how we incorporate our new tools, and then what we think the change is going to be going forward. So we have a very illustrious panel here of innovators and thinkers who will help us to visualize what might be in front of us. And so jumping right in, I think I'm going to start with Gretchen Jackson. Dr. Jackson is a pediatric surgeon, and I want to get your impression of what you think surgery will be in 10 years. Where are we going?
Yeah, well, thank you so much for inviting me. I'm Gretchen Jackson. I'm a pediatric surgeon scientist, currently a scientific medical officer at Intuitive Surgical. Previously spent 12 years as an academic clinician scientist at Vanderbilt, where I still practice pediatric surgery, and then 3 years as IBM Watson Health's chief science officer and chief health officer. I think we are seeing a trend towards surgery being more minimally invasive and more to data and insight driven. And I think we're going to see that explode in the next 10 years. So we've seen surgery progress from open surgery to laparoscopic to robotic and then single port and natural orifice. And now we are moving toward that incisionless surgery, if you will. And we are also seeing an explosion of this world of digital surgery, where we have robust insights that are informing surgical practice and data that are being collected from room cameras, from robotics platforms, from a wide variety of smart devices. And we can start to use that data to inform what happens in the operating room. And I'm excited about that.
So Paul Laviolette is one of our most experienced people in the field, observing the field from the outside and seeing these changes. Paul, can you tell us what you think is happening?
I agree with everything Gretchen said. I think it's going to become a more integrated and a more interdependent operating suite, if you will. Integrated because of all the data flow and because of the systems that will support and over time become more influential in the actual procedure. And we think obviously most manifestly about robotics. Robotics really become the vessel for all of that data flow, and then that data flow turns into a closed loop so that we move from decision support to semi-autonomous activity where the robot and the data are flowing seamlessly into the thought process of the surgeon. And maybe one term that hasn't been used yet is energy in support of that continuum of open down to less invasive and then minimally or super minimally invasive. You are enabling that with novel energies. Mike will talk about one, we can talk about others, that basically reduce the burden of managing that tissue that was the target of the surgeon. So I think it's going to become an integrated operating room with a lot of information flow and a lot of technology.
That's great. And I want to ask Mike to kick us off a little bit with talking about the new energy delivery platforms that we have, including the one that you're intimately involved with, and how we incorporate those into our future.
You bet. It's a pleasure being here. For those not familiar with what we're doing at HistoSonics, so we've got a completely non-invasive surgical or interventional platform that can be used in any procedural suite, which is really important for us to be adaptable to what the physician wants. And the new energy it's not new in that it's ultrasound, but it is new in terms of how we deliver it. So it's incredibly high amplitude sound energy that we use to deliver from outside the body into the body to destroy. Ultimately, what we're doing is liquefying targeted tissue. That can be benign tissue that you want removed, or what we're focused on today are cancer and tumors throughout the body. And when we liquefy those, the body knows how to naturally process that liquefied area. And certainly, we believe the future, literally from head to toe, is using histotripsy when a patient needs it most to treat them non-invasively. But there's a really important world of minimally invasive surgery as well. And what we ultimately want is to do the best thing for each stakeholder, starting with the patient, ending with the physician. And part of our goal is to non-invasively treat a patient to get them to the point of where they're curable, which includes minimally invasive, whether it's resection of the tissue or even transplant of the organ.
It's fantastic. And so our fourth panelist this morning is Dr. Jiping Wang. Jiping is one of our most skilled surgeons, cancer surgeons at Mass General Brigham, and I have to tell you that because I know Jiping won't. And so Jiping represents the end user here, the person who's got to sort out not only how to apply these new kinds of technologies, but which ones to test and how to incorporate them. And Jiping, maybe you can talk to us about how you decide what to use and what new things to try.
Yeah, so thank you, Jerry. So I'm, like Jerry said, I'm a wild card. Actually, I started with, I was an anesthesiologist before I became a surgeon, and then I became a statistician, and then eventually I decided to do surgery. So I'm a late boomer, but I'm a disruptive user. So I like new things, new technologies, and think about a couple of things. One is that how we maximize the ability of current existing technology to expand their indication and develop a new procedure based on the current technology. I call that as an innovation. And also, based on the need from clinical application, what we want to give some guidance to provide some priority for the new technologies, even including robotic or HistoSonic. Give you a few examples, whether we can minimize. I think a minimization of the current technology is key point. Think about it, we can have each OR equipped with one robotic machine. Now it's too big, right? And also we think about how we use endoscopic surgery. We know intraluminal surgery from the intravascular surgery, but endoscopic surgery through the natural orifice. And also, we need to think about not rely on a single surgeon's experience. We have, how about when we do surgery, we combine with surgeon and GI endoscopist together. When we do, one person is good at one organ, the other person is good at the other organ. We have a robot, whether we can, I know other university working on endoscopic robot. It's like, you might have this Swiss Army knife in your pocket. They develop a capsule you can swallow, and the capsule can go through your stomach into the abdomen. Think about do Whipple surgery, we do the dissection, and then when suturing, the small robot can do that for us. And instead of one surgeon to perform beginning to end, everybody has what they're good at. That's my short, brief overview.
That's fantastic. So my summary and observation over the last 20 years is we have had continuous compression of the surgical experience. Compression in terms of the impact on the patient, smaller incisions or no incisions, smaller impact that way, and also compression in terms of the patient's recovery and the ways that they experience surgery. If I can come back to you, Gretchen, what are the barriers to compressing this more? What's stopping us from having everything be outpatient, everything be a minor procedure?
Sure. So I think there are a couple of barriers that are really important. One, we have had people talk about some of the bleeding edge technologies that are available to deliver care, and not everyone has access to those. And that access may be not having access to a particular type of technology, or it may be not having access to the training or the expertise to use it effectively. And I think this is probably one of the more important barriers, especially is the scientific evidence for some of these newer technologies that are infinitely beneficial, sometimes not only to the patient and their families, but also to the surgeons themselves. That some of the leading edge technologies actually make it easier, physically easier for the surgeons to provide care and can prolong their careers when we've invested so many years in training them. So I think, but I think technology can be the answer too. I think we're seeing progressive ways to support or democratize access to care. Some people would say that robotics has democratized access to minimally invasive surgery, and we have seen across the robotics platforms that are being delivered now tools to support telecollaboration, which is a spectrum, which can bring in expertise to an operating room from outside that operating room. And we have seen surgeons delivering robotic care where the nearest robotic surgeon to mentor them may be a couple hundred miles away, and we can bring them into the operating room through telepresence. And I think we're seeing the ability to increasingly support more sophisticated ways of telecollaboration to actually deliver surgery remotely. And I think I think access is a big barrier, but we have technology solutions to help overcome it.
Yeah, I want to reinforce what you said about this being easier for the surgeons or better for the surgeons. One of our surgeons told me that the robot was going to extend his career by 10 years. And the other observation is that we can teach people to do many complex operations with laparoscopy, or straight sticks as we call them, but we can more easily teach many more surgeons to do the same operations with the robot. It is a more natural set of movements. It's a more comfortable thing. It's easier. I think the learning curve, unusually for more advanced technology, the learning curve is actually quicker, I think, for the robot than for the others.
And it's good to hear some people from the late adopter generation saying that.
Right here.
Those of us who trained when robotic surgery was not part of practice.
It was just a dream at that point, I think. So, Mike, maybe I can ask you about some of the technology, the automation of some of the technology, and your platform has some aspect of automation. Maybe you can tell us about that and tell us what you think the limits of automation are in these things that we're doing in the OR.
If you didn't ask, I was going to volunteer some comments on automation, because we think it's critically important to some of the words that Gretchen used, like access, and democratizing not only procedures and who's doing procedures, but where procedures are being done. I mentioned we want a system that fits into any procedural suite to meet the physician's needs. We also want to meet the patient's needs by providing access to therapies, whether it's minimally invasive or non-invasive, in a hospital setting that they prefer, or an ASC setting. One of the barriers I was just going to comment is cost, and how ASCs are currently reimbursed today. But in terms of automation, that we view that as critically important to democratizing procedures for the physician. Anything we can do to automate it and make it easier for the physician to use, again, whether it's minimally invasive or non-invasive, is important. I think the limitations are probably, and rightfully so, at the agency with the FDA and how much they allow automation to make medical decisions. That becomes a challenge with AI. But our goal is to maximize automation as much as we can, especially with a non-invasive therapy. There's no hand skills required of the physician or no instruments that are going into the body. So today we automate the therapy throughout the prescribed treatment volume that the physician makes, but at some point the FDA will ask, well, what is the physician doing here? What are the medical decisions that need to be made, rightfully so, and that's where automation probably hits a ceiling at some point.
So right now, the automation for your device, and I have to say it's remarkable to go in the operating room and see one of these procedures going on. There's like 20 people standing around watching the machine do the procedure. It's really not us doing anything. So right now, the clinician identifies the area of tissue to be impacted, and then the machine kind of takes it from there. So the physician still has a role in targeting.
100%.
And the imaging aspect of identifying what should be impacted.
And I think we'll get into imaging is, because there's no intervention, imaging becomes critical to what we do and enables a lot of the automation that we're focused on, for sure.
And that's a great point, that some of these advances have been our ability to see what we're doing in the operating room, right? The advance from open surgery to laparoscopic surgery was the little camera that you could stick on the end of the scope so that everybody in the room could see what was going on and people could work together, right? The advantages in the robot have been binocular vision and some changes there and the ability to see things in 3 dimensions. Some of the advantages in other technologies are sort of enhanced vision through imaging and targeting through imaging. Paul, do you want to talk about where that is maybe with pulse or other items in your experience?
Well, I agree with everything that's been said. Imaging has moved from visual, topical, I'll say, whether it's in 2D or 3D, now to really through tissues, understanding where nerves are, understanding where vessels are, tissue characterization, and all of that being married into what the surgeon sees and makes decisions about, ultimately to increase accuracy and reduce risk. So that's happening, and we're going to see more blending of imaging technologies in a multimodal approach to enable something far greater than just looking with the eyes. I think that's happening in real time. There are multiple imaging technologies moving forward that will improve tissue characterization and the identification of, I'll call it, just sensitive objects in the operating field. That's underway. I think something like pulse, what's being referred to here is pulsed electric fields as an alternative energy, a non-thermal ablation energy. And an element of that particular energy is that it only, A, it's non-thermal, and B, it only affects tissues with cells. So if you are ablating immediately adjacent to a nerve, that's not going to be affected. If you're ablating immediately adjacent to a blood vessel, that's not going to be affected. So you add increments of safety as a function of imaging and layering in tissue characterization, and then by adding further safety because of some selectivity of the energy being used, you just further reduce the chance for errors in the procedure.
So Jipeng, this sounds great. Like they've solved all the problems for us, but actually I don't think it's quite true yet. Where are the sore points right now when you try to apply these things in the operating room? What are the challenges that we still have?
Yeah, so this all sounds great, but in reality, that at least for now, whatever imaging you use, whatever platform you use, real time is very different. For example, patient have a CT scan, MRI, you can see all the structure very clearly, but in the real situation, when you put the patient to sleep, all of a sudden the position changed. The way they breathe changed. You put some water bath, and then the anatomy distorted. How you invent the technology can synchronize to do the one-to-one mapping from the image you acquired before surgery or instantaneous, same time, real-time, synchronize with the energy device to patient, that's the key point. That's the one thing as a surgeon, we still play a major role when we do a second safety pulse. Although the first safety pulse was coined at Brigham Women's Hospital by two, we have a second safety pulse. Hey, before we treat, nobody touch the patient, no change, and you don't even touch the blood pressure cuff to minimize the variation. But that's just one point. The second point that once we deliver energy, what does that mean to the patient? You know, we as a surgeon, is like breast surgeon, initially when we do the hostile surgery is very traumatic and then minimize now to lumpectomy or central lymph node biopsy, central lymph node dissection. But nowadays, if the machine can kill the tumor by itself, automated, where the surgeon role be, we need to study more when's the best time to treat the tumor, when we treat the tumor, what happened to the patient, whether there's more circulation tumor DNA, circulation tumor cell in patient body, how we monitor it. You know, I think the surgeon have much more roles. For example, there's implantable device for monitor to have a biological sensor. We can do a lot of things in this new technology as a surgeon.
That's fantastic. So Gretchen, I want to get back to this ability to perceive things in the operating room. What we can see, how we can register imaging, where are we headed with the robotic platforms and our ability to use that information in real time?
Sure. Well, I think actually Paul answered that really well at the beginning of this session where he said we're going to a world where that visualization or information is integrated, and then we're using it to close loops of learning or loops of continuous improvement. And I would see that we are seeing now, we are taking imaging, like you said, an MRI, a CT scan, and from which we can generate 3D models, we can print 3D printing to look at a tumor, and we are bringing that into the console view through our 3D model viewer. And our world of the future, we can allow some rotation now and aligning that to what you're seeing in the operating room, and I think we will see even more sophisticated use of artificial intelligence to change that visualization as you are operating to respond to what is going on in the field. I also think we are going to see more integration of the data that are being brought in, whether it is from a robotics platform or a smart instrument or smart devices that is making hundreds, if not thousands, of measurements and generating insights about what is going on, and then feeding that back to the surgeon. So saying, whether it's tissue identification, we're seeing a nerve here, or we're seeing a blood vessel here, or we're seeing the ureter, don't cut that, and providing that to the surgeon. I think some of the challenges that we will be faced, we have so much data now, and it's choosing what insights that we bring in that will be helpful, and which ones will be a distraction. We know that increased distraction will decrease surgical outcomes. So I think we will need science to drive that, which keeps me with a job to do. But I do think we have an exciting future that is, again, integrated and providing platforms for continuous learning and improvement.
Good. So there's two things there I want to talk about. So I'm going to put a bookmark on this feedback to the surgeon thing, and we'll talk about that next, because I think that is really important and really unsolved. So for anybody in the audience who can solve that one, that would be great. But I want to come back to this, the sort of imaging visualization stuff here, because part of what you described is really improved registration of asynchronous imaging, right? A CT scan done a week before, and now we're going to layer that onto what we're seeing in the operating room. There's also the possibility of enhanced intraoperative visualization through real-time imaging with dyes. So there are currently ICG and other kinds of dyes we can put in that we can fluoresce and look at different tissues. But also there may be a future for more specific imaging around molecular findings and so on. Anybody have any insights into that or early data that you're allowed to share?
All I would say is I'll take my CEO hat off and put my investor hat on. A lot of technologies like that are coming, right? There are early stage companies, some of which are already commercial, trying to overcome, I'd say, some of the limitations of let's say, contrast. We don't want to photosensitize, right, every patient in advance of their procedure. But that to me represents the first step in this concept of intraoperative imaging. I agree. It is hard to co-register multiple imaging modalities when some of those images were taken the day before in a different state, could have been a different state, a different patient state. And those are all limitations that to me represent the fact that we're just in the first generation of these things. Yeah. If you look at where we are with robotics as an example, we're still in the first generation. These things are going to evolve relative to where we see them today. And I think what you have to give credit to the industry for is that they're going to evolve at a much faster pace over the next 5 years than they did over the last 5 or 10. So where we see technologies today, whether it's co-registration of images or the closed loop feedback systems within a robot, those are all going to be advancing at a faster pace from today forward than we've ever seen before.
Yes, and I think for you, Dr. Wong, many are working on that ability to see within the operative field whether a cancer is left. That is what every patient asks. Every cancer patient that you operate on asks you after the operation, did you get it all? And being able to look at the operative field and image whether there is residual cancer is something that a lot of people are excited about in the future.
Mike, the imaging is critical to the targeting for your technology as well. Are there advances coming with that, different ways of aiming that energy source or any other energy that we might want to apply?
Yeah, what's great is that we're all sort of, as we advance, we're pushing everyone else to advance with us, including our imaging partners. Mm-hmm. And so there's massive development coming, and it's literally right around the corner. For us, we're using ultrasound for visualization. It's pretty crude, and it needs to get better. Right now, our technology is 100% relying on that, and it's important. Ultrasound is important because, as Dr. Wong said, these patients, when they're on the table, they move, and it's not what the prior day's CT or MR showed. So it's got to be in real time, and because we're not intraoperative, we're non-invasive, it's just slightly different for us. There's massive advancements coming in ultrasound imaging. You're going to see it very soon where, Dr. Wong, you'll be happy to hear this. It looks and feels more like a moving MRI. It is significant. And that becomes critically important, not just for targeting, but also tracking targeting as it moves in real time, ensuring that you're going to get the best possible outcome for the patient. So when they wake up, you can say we've treated it all, you can say that confidently, and they can go home.
Yeah. And we haven't treated anything adjacent that we were trying not to treat. That accuracy is really important for these, especially the percutaneous energy delivery devices. So I want to go back now to this feedback idea and this AI-assisted surgery that we're going to have a sort of AI mentor in the operating room. I had a 25-year-old car. And I traded it in last summer, and the new car is totally different than the old car, right? It's got a heads-up display, and there's all this information, and actually probably more than I can use. And I worry that we don't worry. I believe that we need to pay a lot of attention to what information we deliver to the surgeon and in what way, so that we're helping them and not distracting them, as you put it. So Gretchen, where is Intuitive with working on these things?
Yeah, it's funny that you tell that story because I had that exact same experience with having a 16-year-old car and getting a new car and being like, I don't know what to do with most of these buttons. I think one of the things that we have been working on for several years and collaborating with the surgical community is what we call objective performance indicators, which sounds a little scary. But measuring objectively what happens in the operating room. And I think being able to, and we're doing, but others, again, smart devices measure tissue compression or impedance in tissue and make judgments or even do actions based on that. So not entirely new. But I do think that what happens in the operating room is really the missing piece of the surgical quality puzzle. So that we have, if you look at most of the work on surgical quality, it has been based on the external patient or disease factors. Is it stage 4 cancer? Is the patient obese? Or really simplistic surgeon or institutional factors, like is it a center of excellence, or how many years has that surgeon been in practice? They always ask, how many of these have you done? So, but what was missing is measures of what's happening in the operating room. And I think we have a lot of lore and mythology in surgery about what is really important without necessarily a whole lot of evidence. So we believe Halstedian principles that decreased force on tissue is going to lead to better outcomes, but we haven't been able to actually measure that until now, where we can, with force feedback in our 5th generation, we're in our 5th generation robot, but we can measure those push and pull forces on tissues. So we can actually test hypotheses about, is force important? Is decreased force better? And we're finding, yes, in general, we think it is, that in places where decreased force will lead to better outcomes. But in some places, if you don't use enough force, if you don't pull that suture tight enough, then your anastomosis may be a little loose and leak and so on. So I think what I will say is we are at the very beginning of this journey in learning how this information that we have in the operating room is going to affect clinical outcomes. And that is the body of work that we have to do. Understand how all of this data and the insights we can get are related to outcomes. And I think some people are really scared about this notion of measuring objectively what happens in the operating rooms, but I don't think it's about saying this is good or this is bad. I think it's about giving surgeons more levers to pull to make choices. And I know that if I am doing an operation that is going to get the best oncologic outcome, it may not be the operation that gets the best functional outcome. And I, as a doctor, have to practice at the top of my license and decide with that patient what they want, and then do that in the operating room. And I think these data and insights will give me more tools to tweak what I do in the operating room to get the outcome we want for the patient.
So I think, I believe that the field is actually more ready for that than we might worry. I think there's been a lot of change in the last 20 years, some of it from Mass General Brigham around non-technical skills for surgeons, a lot of which are behavioral, but the ways in which we test, we observe, we do 360 evaluations of surgeons, and we find that those with better behavior also have better outcomes. And so I think this concept that we're going to judge surgeons individually on both technical and non-technical skills, we may be more ready for than we think, which I think would be a good thing. Paul, do you have any thoughts about what this surgical suite feels like to the surgeon in the future when they're getting all this feedback?
Well, the first thing I would say is that it is going to be a partnership between industry and surgeons.
Yes,
I would think as the strategists and leaders at Intuitive Surgical sit around the conference room, they're not thinking about, okay, we're going to drive this change in the operating room, and we haven't really talked to any of those pesky physicians. So it's going to be a real technology development partnership. Human factors, FDA was mentioned. Human factors, big process within FDA. They try to really come to understand how is your technology affecting not only the outcomes for the patient, but the mindset of the user. So that these, and I'll say it, so that these are more intuitive, right? Because they really do want to be able to take a technology, open it up, take it out of the box, if you will, put it in that operative setting, and have it work well, and reduce the likelihood that it works counter to the instinct of the physician. So it's going to be a process that will move as rapidly as the physician community can assimilate it. And I think when those boundaries are stepped over by available technology that is not perhaps ready for prime time, those companies are going to understand that. They're going to slow it down, they're going to pace it, and they're going to make sure that they really work to optimize technology flow to the betterment of surgical practice, not at contrast with it.
That's fantastic. So I'd like to spend these last couple of minutes talking about exactly that interface between the new user and the technology and the company. I started out by saying every generation of surgeons has practiced different than the generation before. The pace of the change now doesn't allow for generational learning. People are going to have to adapt and adopt new technology more quickly than they can go through our routine training and recertification. What is the sort of role and responsibility of companies in the continuing education of the surgeons or other users of these technologies? Mike, maybe you can talk about how you all have approached this.
Yeah, we view that as the onus is 100% on us. I mean, we've got to make it easy for physician, procedural staff, the hospital to be ready for, it's really a new program, whether it's a Da Vinci robot or an Edison histotripsy machine. I mean, you're providing the hospital a completely new program of some type, and the onus is on the companies to make sure that the physician, staff, and hospital is ready for that. So we try to do as much as we can remotely. There are obviously tremendous remote capabilities today, even interoperative teleremote opportunities, and so we try to do as much of that on the front end as possible. And it's still really important then that we have our own company staff in the procedure room with the physicians when they're doing their first case, and up until the point in time where they don't really feel that they need us. I will also comment that the more that we automate, the easier that training becomes. That said, like the car analogy, we're dropping a completely new platform into a procedure room that no one's ever used before. Mm-hmm. So it's no matter how simple the company thinks it is, it's complex and it's hard to learn. And I will say, I know the trendy word is AI. It's like not in vogue anymore to talk about machine learning. Machine learning can seriously help in automation, both in R&D and in the procedural room, and that difference is AI is literally when these computers are making decisions, and again, that's when the agency will take issue to that. It should be a physician making the clinical decisions, but machine learning should come back into vogue, because that is critically important in terms of how fast we advance in development of what we're doing, but also with all this massive amount of data that we have, it's hard to know what to use, but machine learning needs to help a physician guide their decisions. So I'll stop there.
Jiping, can you tell us how you adopt a new technology? How do you bring something entirely brand new into a clinical environment and use it on a patient?
Yeah, so I mean, at our experience, use a HistoSonic example. HistoSonic really set an example of responsibility to help to make sure the technology get used appropriately, and then they take over the training, and also they have on-site support. But as an institution to adopt new technology, we are at the end of the day, we are responsible to deliver the good quality care to the patient. So we have very rigorous credential process other than what the company required. We have steering committee for patient indication, how to select the appropriate patient, to credential each provider we think they are ready to use the technology. At the end of the day, we don't want the technology to fail. It's not because technology is a user. That's why like you said, Jerry, I think that training is such an important component of adopting a new technology.
And Paul, maybe you can tell us more broadly the FDA's view on this and the role and responsibility of both the practitioner and the company.
Well, FDA generally looks in the rearview mirror, I would say. So, with all due respect, they want evidence, and there is a real pinch point, if you will, in that earliest stage of evidence development at a time when something is entirely new. And obviously, every technology has to go through that process. I think it's up to the company to really define the vision and then set that clinical strategy and that evidence development strategy in place to build the foundation that will both appease FDA for clearance purposes and then appease at least the early adopters in any clinical community that this is ready for use. And then I think we're going to go through what has been in the past more of a significant stepwise progression, right? The first robots come out, there are physicians who take the plunge, become robotic surgeons, others who say that's not for me. And that's now moved forward with significant penetration. I think going forward it's going to be one more of continuous flow, continuous expansion. No one's going to define themselves binarily as, oh, I'm not a robotic surgeon. Robots will be ever present, as an example, and their influence on surgical practice will be continuous. And that will move out of the hospital into the ASC, and large-scale robots will become smaller. More and more processes will become automated. So it's now going to become, I think, more continuous flow rather than just on and off as we've seen in the past.
Very good. Well, I want to thank first the panel for all of your insightful comments, and it was very helpful for me. I hope you all in the audience who lent us your time today enjoyed this as much as I did. Thank you all.